Hey guys, it's Dr. Makuve here. So you're aspiring to become an acute care physical therapist. What do you need to know about acute care physical therapy? Well, first of all, what is the job of an acute care physical therapy? In short, it is to facilitate an appropriate discharge for a patient. What are the different places that patient could end up going to after an acute event? Well, they could go home if home is where they're coming from, or they could go to a skilled nursing facility. They could go to to an acute rehab facility, or they could go to a long-term care facility, or wherever else they could end up going, a brother's house, a family's house, wherever they end up going. But what you need to do is first of all understand what their prior level of function is, what they were able to do before, and then understand the diagnosis that brings them here. So for example, if a patient had a dense stroke, for example, the likelihood that they are going to go back home and be able to do the things they were able to do is very slim. So you know the pathology, you know the disease, and you are the expert who understands what it's going to take for this patient to get back to their normal function. So going home for that patient is very inappropriate. However, a patient that comes in after an appendectomy, for example, 26 years old, is more than likely going to go back home and be able to do the things they were able to do, say, in about 2 or 3 weeks. So that's the job of an acute care physical therapist, is to be able to assess what a patient's current status is, be able to understand the pathology and the diagnosis that brings them into the hospital, and then formulate a time frame upon which the patient might be able to go home. Now, understand one thing. As a physical therapist, you're part of a team of people in the hospital. And the team is comprised of nurses, physicians, other therapists, like your speech language pathologist and occupational therapists. Medical stability is the one criteria that says that a patient does not need nursing services 24/7 anymore, so they can go somewhere. And typically that's when the physicians are coming in asking us on a daily basis, when do you think the patient can go home? If they can't go home, where do you think they need to go? What are the things that they're not able to do right now that are preventing them from going home? So your job is to try and expedite the discharge home, because the longer a patient stays in the hospital, the more likely they are to contract something that they didn't come in with. So now let's go into the evaluation of the patient, because that's the important part. You want to know how to do this right. So the first thing you want to do, like I said before, you want to read the chart and look out for very specific information. You want to look at the lab values. As a physical therapist, you have certain lab values that are important to you. For instance, any lab values that pertain to the perfusion of oxygen in the body are important to you, because they tell you how well the patient is going to do when you start exerting the patient and increasing the oxygen demand on their body. Also, any lab values that pertain to the coagulation of the blood is also very important. So either the blood is too thin and there's a high probability of them bleeding, that also gives you a moment of pause. How much can you do and how much is safe? And on the other hand, you can have patients who actually have blood that is clotting or is at the risk of clotting. In those cases, what are the chances that activity move a clot along to save the lungs? So in any case, you're looking for these values that tell you different things. The state of the muscle of the heart. You have a lot of values that would tell you a number of things about the state of the patient as they sit right now. Now, your job is to evaluate and make sure that this patient is going to be safe to mobilize. In any case, even if the patient is not safe to mobilize, I'll give you one thing that's really important to understand. Most patients are going to need to do something. Whether they are laying in bed all day long, whatever they're doing, they need to be able to do something. So I have seen a lot of physical therapists who walk in and they say, oh, the troponin is too high, I'm going to walk out. And I always ask the question, but do you think this patient will need to eat? Do you think this patient will need to sit? Do you think this patient will need to shift their weight so that they can offload themselves and prevent pressure injuries? If the answer is yes, then yes, an evaluation can be performed in the context of the lab values that the patient has. If a patient is on bed rest and they're not allowed to move at all, that is a good reason to not mobilize that patient. But in any case, I always find most of my patients, regardless of what the lab values are, there's always something of value that I can do for them. Again, in the context of, if I don't move them or if I don't teach them to do something where they are, there is a high chance that they might end up developing something secondary to what they have that is being caused by immobilization that might cause them problems and cause them to stay in the hospital for a lot longer. Not only is that a financial burden, but it's also an emotional burden on the patient. And we as physical therapists can look at ourselves and say, we failed that patient. I don't want you to be that physical therapist. So let's move on to the next thing. You have cleared the chart and everything looks good. You walk into the room and you want to verify that this is the right patient that you're seeing. You would be surprised how many times we walk into a patient's room and the patient's room has been changed. The patient is now in a different room. And if you don't verify that, you might end up treating the wrong patient. Now, that may sound like, well, what's the worst case scenario? We don't give medications. It's not like we're going to kill the patient. No, we do have things like weight-bearing status that are very important. If you come and treat a patient who has a non-weight-bearing weight status as someone who has a partial weight-bearing or weight-bearing as tolerated weight-bearing status, you could harm that patient and end up landing them in the OR again. So don't do that. In any case, verify to make sure that this is the right patient. Once you verify that this is the right patient, find out the things that I think are really important. First of all, is your patient alive? The way you do that is by taking the vitals. Fortunately, if you're on a high-level floor, like say the ICU or IMC, intermediate care unit, or intensive care unit, there will be equipment all over the place where you either can just push a button and check the blood pressure, or you can just look on the wall and you can see what the blood pressure is. But if you don't have that, you're going to have to manually take the blood pressure, the heart rate, and I would recommend that no matter what you do, if you're going to take heart rate, do it the old-fashioned way. I have seen equipment fail all the time and sometimes just not do as good a job as you would with just palpating the radial artery. But in any case, let's suppose that everything checks out and your patient is alive. The next thing you want to find out is your patient okay in the head? Can they participate at a level that you would consider a good level to participate in this therapy session? So you want to find out if they're oriented, if they know who they are, where they are, and if everything checks out. Now you're going to ask them for the most important thing, which is the consent. Is it okay for me to work with you today? Explain what it is that you do and why it is important in the grand scheme of everything that is going on. And what I try to tell my patients, because every time you walk in and you say you're a physical therapist, they immediately have this visceral feeling inside of them. They hate you. They want you to walk out and just never come back again because the word physical is involved in this whole thing. But when you explain to them that I am part of the team, one part of the team is taking care of your medical capabilities and they're trying to make sure that you are medically stable. I am part of the team that makes sure that your physical abilities are such that when you're medically stable, you're able to walk out of this hospital and go back home, if that is within reach for this patient. If not, of course, you want to make sure that you're honest with the patient and you explain to them what the possibilities are. Now comes the evaluation. Now, there are predetermined steps in acute care. One is the ability for the patient to have what we call bed mobility. Bed mobility, simply stated, is the ability to mobilize in the bed. It's the ability to scoot in the bed from left to right. It's the ability to roll in the bed from left to right. It's the ability for them to scoot up in the bed or scoot down in the bed. And there are very simple exercises that you can do with these patients. One of them is to teach them how to bridge. When a patient bridges, they're engaging the glute muscles. So you can make that into a therapeutic activity that allows them to scoot up their buttocks and then move to the left or move to the right. That is an activity. Or you can make it into a therapeutic exercise where you ask them to do it 10 times, asking them to squeeze their buns together as they engage the one muscle that is going to atrophy really fast from laying on your back doing absolutely nothing. That's an activity that they could do between now and the next time you see them. Once your patient has figured that out, or you figured out where they are with that activity, you explain to them why this is important. Not only is it important for you to strengthen your glute muscles, but it's also an activity that helps us so that we don't have to care for you as much as when you're in the hospital. In other words, you're not pushing the call light every time you need to scoot up or scoot to the side in the bed. Now, the next activity is also important. Rolling to the left or to the right. Your patient might need assistance. They might need to hold onto a side rail as they roll over to the left or roll over to the right, but you want to train them to be able to do that independently. Because more than likely at home, they don't have any rails, they don't have anybody to help them out. So you teach them the body mechanics of just rolling their body to the left and the right. And the importance of that, not only is it the initial step in the process of sitting up, but it allows the patient to offload pressure off their ischials, offload pressure off their back so that they don't have pressure injuries, which is another reason why patients have these secondary injuries from laying down in bed for a long time. Now that you've explained to your patient why that is important, your patient is starting to buy the story that you're telling them, that you are a very important part of this team that is going to bring them back to health. The next thing you're going to teach them is how to transition from a sideline position to a sitting position, dropping those legs off the edge of the bed, creating enough momentum so that they can start coming up to a sitting position and pushing themselves with their arm to come up to a sitting position. Again, a patient who's sitting sees the world in a very different way. As soon as they're sitting, you're going to start assessing their balance. A patient in a sitting position, unless they have restrictions on bending and twisting their lumbar spine, can turn to the left, turn to the right, they can reach back, they can reach up, reach to the side, they can also reach outside of their base of support and maybe pick something up from the ground, which would be the most difficult thing for them to do. But in any case, assess how well they do in a sitting position. Now remember, your patient who's laying supine in bed has already had their blood pressure taken, their heart rate taken. The moment they sit up, you want to do exactly the same thing and ask them how they're feeling. And if you had to explain why you're doing this, it's really simple. If a patient has been laying in bed for 2 weeks, they sit up for the first time, their heart is not conditioned to pump against gravity. That's a reason why the heart is just a little bit weaker to pump enough blood to perfuse the brain. This is why your patients who have been laying for a long time sit for the first time and they pass out, or they start getting dizzy and lightheaded. And when they stand up, it's even worse because now the heart has to pump blood all the way to the extremities and come right back up. Gravity basically is working against them. So in any case, it's going to take them a little while to get the heart, which is a muscle, to get conditioned again to be able to manage pumping blood against such resistance. That's the explanation you want to give your patient. It's easy for anybody to understand. Your patient who's in sitting and has good sitting balance is a good patient to start teaching how to stand up. But remember that a patient with poor sitting balance will never have good standing balance. A patient who cannot sit cannot stand, and a patient who cannot stand cannot walk. And you'll be surprised how many times I've seen therapists who are trying their best to get a patient who cannot sit to walk. That's called dragging a patient down the hall. It never works. Teach patients how to do the things that they're able to do at this point and get them to be really good at that before you move on to the next step. A patient who is able to sit but unable to stand can be taught how to transfer into a wheelchair, transfer to a bedside commode, or transfer to a chair so that they can play bridge, bingo, whatever it is they want to play in the room with their family members when they come in. Once your patient is sitting, you want to teach them how to stand. And the routine there is very specific. You want to teach them the proper way of doing it, and you want them to be successful. Put your feet about shoulder width apart. I want you to scoot forward. Keep your back nice and straight. I want you to look up just a little bit. That will straighten your back up. What you're trying to do is teach your patient how to have a neutral spine, lean forward, hinging right at the hips so that they can use those glute muscles that they've been training while they're doing their bridging exercise to come up to a standing position. Migrating their center of mass over their base of support and then using their leg muscles to come up to a standing position. Once your patient is standing, of course, you want to test their standing balance, which could start with perturbations. You can go into something like a 4-stage balance. And then once you're satisfied that this patient is safe to stand, if they're not safe to stand, you need to decide what kind of assistive device they need to be able to stand properly. Now you can start assessing how they walk. You can assess how they transfer. And then once they start walking, you want to measure the distance that they walked and then give a context of how that relates to their life at home. Because at the end of all this, you want to give your patient what the sequel is going to look like tomorrow when you come back. What are we looking forward to? So this is what it sounds like. Mr. John, Mrs. Smith, today you walked 220 feet, which is a good distance for the first day after a total knee surgery. I'm very impressed with how you did. However, we are looking to get you to about 500 feet, which is about twice the distance that you've done today. So here's what we're going to do. When we come back tomorrow, I'm going to see if we can get you to about 300 or 400 feet. But between now and tomorrow, I am going to tell your nurse that it is okay for you to walk about 100 to 200 feet with them. If you do that about 3 to 4 times a day, I bet by tomorrow you'll be able to walk that 500 feet. What did we just do then? We told the patient how they did. We congratulated them for being able to do what they did. We got some buy-in into the program, and we gave them something to anticipate tomorrow, which is we are going to walk so many feet. But at the same time, we gave them a responsibility to walk between now and the time I come tomorrow. This is how you become an effective communicator and also an effective acute care physical therapist, by making sure that your patients understand where they are in relation to where they need to be. And then every single day, you give them an update on where they are and what they need to do to be able to accomplish the goals. So when all is said and done, there's one person who is very interested in what the results of this evaluation or this assessment or this treatment was. It's the nurse. The nurse wants to know, how am I going to care for this patient for the next 23 hours that you're not here? This is what we call the S-bar. You're handing over to the nurse and you're saying to the nurse, listen, Mr. John just walked a good distance, 200 feet. The nurse couldn't care less what 200 feet means, but at least you've told them what it is. But what they need to know is it safe for me to walk with the patient when they want to go to the bathroom? And the answer to that for this patient might be yes. They can go to the bathroom, but they need at least 1 or 2 people to help them out, get onto the toilet and off the toilet. The nurse also wants to know, how are their vitals? You're going to explain to the nurse that their vitals were good, stable. I checked their SpO2 throughout the entire process, and it only went down as far as 96%. Well, that's great. That's information that's great for the nurse to pass on to the physician who is responsible for the final discharge of the patient. If there's anything that was of concern to you, for example, when they stood up for the first time, the blood pressure went down. Well, you want to explain what that was and how long it took for them to recover. Again, very important for the nurse because they're going to pass that information to the physician. Sometimes it may require specific intervention from the physician, or it's just information that tells us that the patient is progressing or regressing. But in any case, pass that information to the nurse and then write a detailed note that touches on the key points, specifying exactly what the goals of the patient are, what their prior level of function is, where they are today, and where you expect them to be in the next 2 or 3 days before they discharge. But the most important thing that every physician is looking for is, if this patient was medically stable today, in other words, they didn't need 24/7 nursing service, where could they go today? Where do I discharge them to? Do I discharge them home? Do they go to a skilled nursing facility? Do they go to an acute rehab facility? And the answer is going to lie in a number of things. One is their participation level. Were they able to accomplish the things that you thought they should be accomplishing at this point in the game? If the answer is yes, then you know that the prognosis is good. The support system. Who else is at home that can help them? Is that person healthy enough to help them? Do they have a job that they go to that takes them away from the house? Those are important details. The more you spell out the entire picture of what the home life looks like, the easier it is for the insurance company to understand that, well, yeah, patient has a spouse at home, but the spouse works at night. That means the patient is unsafe when they're most vulnerable at night, when it's dark, and if their balance is not so good and they need to go to the bathroom in the middle of the night, they're at the risk of falling. Insurance companies are not dumb. They understand that if a patient falls, that's going to cost them more, right? Now that you're done, you're going to come back the next day. You're going to assess this patient as if they were a brand new patient, because God knows what happened yesterday when you saw the patient and today. Sometimes those patients will surprise you. They're doing so much better. The 500 feet that you were expecting them to do, they're doing 800 feet, and they're going up and down stairs, and they're doing well, and they're ready to go home. Sometimes the worst has happened. They crashed overnight. They took some medication that made them really loopy, and they cannot participate anymore. They got intubated, and now they're in an intensive care unit. Anything can happen. In the next video, I'm going to talk to you about how to assess a patient who has moved from one unit to the next. These are upgrades and downgrades. Understanding exactly how to look at the consults for physical therapy and understanding which physician is putting in that consult, if that's a consult that is appropriate for you to follow, or if you need to find the appropriate clinician to put in a consult for you. But in any case, I welcome you to being an acute care physical therapist. It is an exciting journey. You will learn a lot more than you will learn in any other setting because you are surrounded by professionals who are at the top of their game and you are a part of a team. So being able to function in that team is probably one of the most important things that you will learn in your career as an acute care physical therapist. So good luck to you. If you have any questions, please put them in the comments below. If there's anything that I missed that you want me to show you how to do, please let me know. Again, my name is Dr. Ephraim Makuve. I am an adjunct professor at Touro University. I'm the CEO and founder of Wutano, and I am glad that you have an interest in acute care. I wish you the very best of luck, and we'll catch you on the next video. Thank you.